we can go to the next slide. Here we go. So the abruptio placenta is actually the most common cause of antepartum bleeding. It literally is bleeding either at the edge or behind the placenta, and it occurs in as many as 1 in 100 births. You can go ahead and click. It's going to bring each one in separately. Overt hemorrhage is pretty easy. Patients just have severe dark red bleeding. It's pretty classic. They have tachysystole. The uterus is really contracted down. Uterus is tender. Typically, when they have a significant amount of bleeding, you will see some evidence of an abnormal fetal heart tracing. And at its worst, the patient will exhibit fetal demise as well. The ones that I see people get in trouble with are those concealed placental abruptions, which account for about 10 to 20% of placental abruptions, where the blood is, as in the picture here, is totally concealed behind the placenta, and there is no outward bleeding. And the patient will have typically the same symptoms, the pain, the tachysystole, but people attribute it to violent normal labor and can get lulled to sleep with that. The one thing that you do see with this, in addition to all these symptomatology, is maternal tachycardia. So when you see significant maternal tachycardia that doesn't slow when she is not having the contraction, that should give you at least some clue. The ones that we talk about the most are the acute abruptions that occur with just no good reason, onset of heavy bleeding and the pain. We do see a lot in the office of these chronic marginal abruptions where we believe that there's mild separation at the edge of the placenta. They have the dark bleeding that comes and goes, comes and goes. Now, those chronic and marginal abruptions can certainly progress into a severe and more complete overt abruption, but they typically are just a nagging clinical dilemma for us, how to manage the patient and when to deliver those folks. And this is a clinical diagnosis. There's lots of literature now. In the past, the old literature said you would see less than 2% of abruptions on ultrasound. With the quality of our ultrasound equipment, you likely will see more than that, but typically the diagnosis is clinical. By the time you get the ultrasound transducer out, if you really are having that difficult a time with making the diagnosis, you wonder whether it truly is an abruption or not. You certainly can see the subchorionic hemorrhages and the marginal abruptions at the lower edge of the placenta. But if you are concerned about a severe overt abruption, you will end up delivering the patient based on clinical acuity, not looking at the ultrasound. Next slide. So again, severe abruption, over 50% of the placenta is separated. They're almost always abnormal fetal heart tones. It generally will start with subtle late decelerations, and it progresses to much more significant with decreased variability. The coagulation studies, abruptio placenta, we all know one of the catastrophic end results is DIC and fetal demise. And fibrinogen is typically the first coagulation study to go to the abnormal range. And those of us who take care of pregnant patients understand that fibrinogen is normally a little bit more elevated in pregnancy. So if it's less than 300, it starts to raise our eyebrows and a concern about an impending coagulopathy. If a patient shows up with a clinical abruption and a fetal demise, the blood loss you should just assume is at least 2 liters already. And if DIC is not there, it's underway. Those patients need rapid evaluation and blood product administration to maintain maternal vascular system from collapse. Next slide. So this is a classic large abruption. This is a severe, over 50% of the placenta. The picture, if you've seen one, this is it. Risk factors for abruption. Hypertension is the #1 risk factor, and it's also the #1 risk factor for severe abruptions associated with fetal demise. Smoking is also a dose-related phenomenon, and if you combine that with hypertension, it significantly increases the risk of abruption. And that's one area that we can really impact the incidence to decrease abruptions by getting moms to decrease the amount they smoke. Cocaine, we still see a fair amount of cocaine use, and with each use in the 3rd trimester, there's a 10% risk of an abruptio occurring. So that's very significant. Minor trauma, that coup, contra coup, decelerative injuries, not associated with abruption a lot, but the incidence is quoted to be between 2 and 5%. Severe trauma can lead to a much higher risk, even as high as 25 to 30%. And it's generally a catastrophic, rapidly occurring abruption. AMA, multiparity lead to are associated with a higher risk. PROM, about 2 to 5% of patients who have preterm rupture membranes will develop an abruption. Patients who have polyhydramnios, particularly if they rupture their membranes from that rapid deflation. Same thing with the twins, a higher incidence of abruptio. And if a patient has had one prior abruption, the risk of recurrence is about 15%. If they've had 2 abruptions, the risk is about 25%. So pretty significant. So the management of abruption, remote from term, it just depends on how sick the mom and how the baby looks. If it's an overt abruption, they're bleeding a lot, the answer is delivery. If they have bleeding that is significant, but mom is stable, baby is stable, you're highly suspicious that this is an abruption, continuous fetal heart rate monitoring, steroids, magnesium sulfate for fetal neuroprotection is certainly reasonable. People always talk about not giving tocolytics if a patient's bleeding. That's kind of a guide, it's not a rule. Certainly you can give the magnesium sulfate for neuroprotection, and a lot of times it will calm the uterus. The blood acts as an irritant and makes that uterus just really clamp down off and on, and many times the magnesium will help settle that. If it's an overt abruption that's continuing to develop, nothing's going to stop that uterine activity, and you're going to have to move toward delivery. Serial labs watching coagulation studies, fibrinogen plus the other DIC labs are important. If she comes in at term and is believed to be abrupting, whether it be a marginal abruption or more significant overt or concealed abruption, delivery is the answer. The route, always you prefer vaginal, but many times, particularly in a developing abruption, when you start to see fetal heart rate deceleration, to cesarean section is needed. One of the hard things, and a question that I get not infrequently, is how do you manage the patient that comes in with an overt severe abruption, a fetal demise, and in DIC? Always try to stabilize mother. Blood products, try to get their coagulation status at least on the mend. And my feeling is vaginal delivery is always the best if you can attain that. But many people feel that rapid emptying of the uterus by doing a cesarean section is probably a reasonable option, but I would say only do that if you have the patient at least on the way to stability with blood products. It's different if she comes in and you've got a baby crashing and you've got an abruption, you have to operate immediately, and I get that. But if there is already a demise, be cautious, deliberate, and manage the patient to stabilize her first. Again, severe abruption, you just deliver. Marginal abruption, it depends on how much they're bleeding as to when you deliver those patients and whether you manage them as an inpatient or an outpatient. You just have to make that decision clinically, and it's not always an easy decision. And if we have time, one of the cases that we're going to present today has to do with a patient that we believe to be a marginal abruption. Next slide. So placenta previa is where the placenta covers a portion of the cervix. Low implantation, a low-lying placenta, is where the placental edge is 2 to 3 centimeters from the cervical os. A marginal placental previa, some people call it partial, I call it marginal placenta previa, is when the placental edge is closer than 2 centimeters to the cervical os, and it can cause significant bleeding. And then a complete previa, obviously, the placenta is covering the internal os completely. Placenta previas, they typically present with the bright red bleeding. Sometimes they may have contractions, sometimes they may not. It can just occur for no reason. It's always the chicken versus the egg. When they come in contracting, was it the contractions that led to shearing of the placenta and the bleeding, or was it the bleeding that occurred first, caused irritation of the uterus and then contraction? So it can happen either way. The incidence is about 1 in 200, and obviously one of the risk factors is prior cesarean section. If you've had one prior cesarean section, the risk of a previa is about 1 to 2%. If you've had 2, it's 2 to 4%, and it goes on up. If you've had 4 to 5 C-sections, the incidence is 10%. And if you've had a prior previa, the risk is 10 times elevated. So quite significant association with prior C-sections and prior previas. I mentioned that you could be having contractions with these patients, and certainly tocolysis with magnesium sulfate can decrease those contractions, and actually has been associated with decreasing the bleeding, at least initially, allowing time for steroids, and is worth a try, particularly in preterm patients. Obviously, cesarean section is required for delivery. We do try to delay delivery for steroids if the bleeding stops, but obviously if a mom comes in early and is bleeding significantly and it's not stopping, you have to proceed for delivery. Rule of thumb that I always like to teach the medical students and residents is that 1/3 of patients with a placenta previa will bleed before 30 weeks, 1/3 will bleed between 30 and 36 weeks, and then that last third will either not bleed or will bleed after 36 weeks. And it's one of the reasons that we really choose that 36 to 37 week mark to talk about delivering these patients, even if they have not been complicated by bleeding during the pregnancy. Recurrent bleeding is the rule. If a patient has had a prior episode of bleeding with a previa, they need to understand it's going to happen again, and they need to be very cautious, be prepared for it, and get to the hospital if you're managing them as an outpatient. We'll talk a little bit about outpatient management as well. Severe anemia is definitely possible with these, and I didn't mention it with the abruption, but you can see significant neonatal anemia with either abruption or previa, so very common. But coagulopathy is less common with a previa. You see much more maternal hemorrhage and the platelets go down. You certainly can see that, but not nearly like you do with an abruptio placenta. Next slide is just a nice picture, an ultrasound picture. You can see the mom's bladder is the black circle down there, and the placenta is labeled, and it's overlying the placenta. The one thing that you'd learn as a medical student is if you know that there's a placenta previa, don't stick your fingers in there to check the cervix, because it can dislodge that placenta, shear it away, and you can have a massive hemorrhage on your hands. The other thing that you tell these patients in the third trimester is nothing in the vagina, no coitus, because that can lead to a significant amount of hemorrhage in these patients. Next slide. So the management with these patients when they come in, obviously aggressive fluid resuscitation, blood products is needed. I do think tocolytics can be helpful, particularly in trying to buy a little bit of time for the steroids to be of benefit. And we use magnesium sulfate for that, as well as for neuroprotection. And again, get those steroids on board. Mom's RH negative, if it's a bleed before term, before you deliver the patient, RhoGAM should be given. And if one bleed occurs again, a second one is going to occur. It's just as a matter of time. Next slide. And this is probably the one bit that is the most debatable, and many people don't manage or don't like to manage these patients as outpatients. I do think that it's safe if it's the right situation. If the patient lives, within 15 minutes, 20 minutes of the hospital and is reliable, and they have stopped bleeding, and I've watched them for a few days and they've not had any further bleeding, I will consider sending that patient home and follow her up as an outpatient. I see them often in the office and watch their hemoglobin. I like to maintain their hemoglobin at greater than 10. And that's just a preference of mine. If they don't have good transportation, if you're really concerned that they're not going to follow up and not really going to do the things you ask them to do, inpatient is the safest. If they come in the first time with bleeding, my rule of thumb is to watch them for 3 days without bleeding, and then I would consider sending them home. The second time they show up, I admit them for a week or more. If they are really quiet, don't bleed anymore, I might consider sending them home then. But if they come in a third time, they stay until delivery unless they check themselves out against medical advice. Delivery timing for a placenta previa, 36 to 37 weeks. I lean more toward the 36 weeks, particularly if they've had bleeding. If I have them in the hospital and they've had recurrent significant bleeding, we'll move that up to 34 weeks and sometimes even earlier if needed. But that's just kind of my rule of thumb in managing these patients over the years. They just make me extremely nervous. One other thing about a placenta previa that has been debatable, but we do serial growth ultrasounds on these patients because there's some data to suggest an increased risk of fetal growth restriction when the placenta is a complete previa and implanted over that lower uterine segment. So that's just one of those things that I tell the residents, and I also restrict their activity somewhat. Again, definitely trying to get them to understand the need not to have sex with a complete previa. And I'm going to stop there.
All right. Thank you, Dr. Campbell. A announcement is that our next module is going to be beginning on July 21st, and we will be covering didactics focused on sepsis. And if you would like a video recording of Dr. Campbell's presentation, you can contact me directly.